The biggest proponent of this was last year's adult panel. Dr. Trivedi from Texas did all the STAR-D research on the effectiveness of antidepressants using an instrument that he developed that was patient administered. So the patient would fill it out, bring it into the physician would review the patient's understanding of what was going on with that patient, and that would help the doctor structure what it was they were going to do and what they would talk about. Just a little bit of data. As we go around doing these presentations, we try to get both psychiatrists and various kinds of primary care physicians, pediatricians, family practice, and people have asked us, well, why bother with primary care type physicians? So here's a few graphs to try to illustrate that. This first one is the percent of prescriptions for these three classes of drugs at the bottom: antipsychotics, antidepressants, and stimulants. The dark bar is psychiatrists. The pink bar, or whatever color that is primary care physicians, or essentially every other physician other than a psychiatrist. And you can see by far for antipsychotics and antidepressants, psychiatrists write way more scripts than primary care. Stimulants, primary care actually writes a little bit more. When you look at it another way and you say, all right, let's identify every physician out there that wrote a script for a mental health drug in the last 6 months or the last year, what percentage of those are psychiatrists versus other specialties? You get a reversal of the trend. So you see that the non-psychiatrist group, significantly more physicians writing antipsychotic, antidepressant, and stimulant scripts than psychiatrists. So what it means essentially is, and this is for data for kids, that there's a lot of doctors out there, primary care type physicians, each writing relatively small numbers of scripts in these different categories. This is the same data for adults. This first one again is the percentage of prescriptions. You can see for antipsychotics, again, psychiatrists write way more than primary care. For antidepressants, and I don't think this would surprise anybody, primary care writes a little bit more than psychiatrists. The difference gets even larger when you look at all the prescribers of these classes of drugs. And by the way, this is all Medicaid data. You see that non-psychiatrists are way more than double for antipsychotics. For antidepressants, I can't divide quickly enough to do that, but it's a huge discrepancy. So there's a lot of primary care physicians out there doing relatively little of this work, which I guess is sort of a reasonable target for education and quality assurance type programs, because while many of them may be pretty familiar with these drugs, many may not, since they're not specifically trained in them and they don't use them very often. As Alan said, we're going to focus on the medication treatment guidelines today, particularly the new ones related to children. Just a little bit about the guideline development process. We do this once a year, alternate 1 year adults, 1 year children and adolescents. We bring together somewhere between 20 and 25 primarily physicians for a 2.5-day meeting. With the child group, we included primary care physicians. We always have representatives of all the departments of psychiatry, physicians that work in private practice, physicians that work in managed care organizations, physicians that work in community mental health. In other words, trying to get the academic experts together with the people that are on the front lines actually doing the work on a day-to-day basis, try to bring those things together. And the idea is to update them every other year, which is more frequent than any guideline that I'm familiar with. And the reason for that is there's a lot of new data coming out about what works and what doesn't, and side effects and various kinds of things. So we think our guidelines should be given serious consideration, even over some maybe more prestigious ones, because they're more current. And we bring in top-notch researchers to make sure that we have access to the most current data. So the child guidelines, we initially developed them in '06. We updated them last July. The update, there's a great deal more detail on the treatment of preschool-age children, which is really a hot topic both in the media and for ACA. Much more specificity on dosing of the major classes of medication, includes recommended starting dose, titration, target dose, maximum dose, and even tries to make it as much as possible disorder specific. So the guidelines for children, other than the preschool children, it's 6 to 17 ADHD, bipolar 1, which the group was clear about was classic bipolar disorder, which would exclude a lot of children that may be diagnosed with bipolar disorder, major depression, and chronic compulsive aggression as a whole separate set of target symptoms to deal with that, at least in the little bit of research that I've been able to do on that. That seems to be what really is driving antipsychotic use in the vast majority of kids, and I'm sure that's no surprise to you all. Adult guidelines, schizophrenia, bipolar disorder, and major depression. This is my last slide, and this is the website. All the guidelines can be accessed on this website, and all kinds of additional information and commentary that was developed with the guidelines. We tried to put the guidelines in a form so that people could carry them around, conveniently look at them and actually use them. But in doing that, we simplified them. So there was lots of discussion at the expert panel meeting that couldn't be put on the printed guidelines, but a lot of that commentary is available on the website.